Healthcare organizations track patient safety using measurable indicators, but many simulation programs operate completely separate from those metrics. That's a missed opportunity. If simulation is going to be viewed as strategic infrastructure rather than just training, simulation leaders need to understand the same safety indicators that hospital quality departments track every day. Many of these indicators come from the work of the Agency for Healthcare Research and Quality, which developed a set of patient safety indicators, often called PSIs. Today I want to walk through 10 patient safety metrics that simulation programs can directly influence and explain how simulation can help organizations reduce risk and improve outcomes. Historically, simulation programs in healthcare were created to support education. They trained students, they trained residents, they provided opportunities for clinical staff to practice rare procedures. And that work is still incredibly important. But the healthcare safety movement has changed dramatically over the past 2 decades. A major turning point came in 1999 with the publication of the landmark report, "To Err is Human: Building a Safer Health System" by the Institute of Medicine. That report estimated that tens of thousands of Americans were dying each year due to preventable medical errors. The report reframed safety not as an issue of individual competence, but as a systems problem. Hospitals began to rethink how they identify and manage risk. Out of that movement came the development of patient safety indicators, often abbreviated as PSIs, created by the Agency for Healthcare Research and Quality. PSIs are data-driven metrics derived from hospital administrative data that help organizations monitor potentially preventable adverse events. They provide hospitals with a standardized way to measure safety outcomes and compare performance across institutions. These indicators matter because they influence several critical dimensions of healthcare operations. First, PSIs are deeply embedded in hospital quality improvement programs. These teams continuously monitor safety metrics to identify trends and prioritize improvement efforts. For example, if a hospital sees an increase in post-operative respiratory failure or sepsis rates, quality leaders will often launch targeted improvement initiatives. These initiatives may involve new protocols, staff training, workflow redesign, or new monitoring systems. This is exactly where simulation can become incredibly valuable. Simulation allows teams to practice new protocols, test new workflows, and train staff in high-risk situations before they occur in real patients. Rather than introducing a new policy and hoping it works, simulation allows teams to stress test the system. Patient safety metrics increasingly affect hospital reimbursement. Federal payment programs administered through the Centers for Medicare and Medicaid Services link hospital performance to financial outcomes. Programs such as the Hospital Value-Based Purchasing Program and the Hospital Acquired Condition Reduction Program adjust reimbursement based in part on patient safety metrics. Hospitals with higher rates of preventable complications can experience significant reductions in reimbursement. That means patient safety is not just a clinical issue. It is also a financial and operational issue. When a hospital experiences a high rate of complications, such as central line infections or post-operative sepsis, the impact can include increased patient harm, longer hospital stays, higher treatment costs, reimbursement penalties, reputational risk. Simulation programs that target these safety metrics are therefore contributing directly to organizational performance. When simulation leaders understand the metrics being tracked by quality departments, they can align their training programs with the risks that matter most to hospital leadership. Patient safety metrics also play a role in hospital accreditation. Organizations such as the Joint Commission review safety performance when evaluating hospitals. Accreditation surveys often examine adverse event trends, root cause analyses, improvement initiatives, staff training programs, organizational safety culture. Surveyors frequently ask hospitals to demonstrate how they are addressing high-risk safety issues. Simulation can provide strong evidence of proactive safety management. For example, Hospitals may demonstrate team training programs for rapid response activation, surgical team simulations addressing retained surgical items, interdisciplinary communication training, crisis management simulations. When simulation programs align with safety priorities, they become a visible component of the hospital's overall risk management strategy. Another reason safety indicators matter is the increasing emphasis on public reporting and transparency. Many patient safety metrics are reported through national benchmarking programs and publicly accessible databases. These reports may influence hospital rankings, insurer contracting decisions, community trust, physician recruitment, patient choice. Hospitals increasingly monitor their safety performance relative to national benchmarks. A high rate of complications such as falls with injury or central line infections can quickly attract attention from leadership. This is why patient safety is no longer just a clinical issue, it is also a reputational issue. Simulation programs that focus on these metrics help hospitals demonstrate that they are actively working to reduce preventable harm. For simulation leaders, the key insight is this: many simulation programs operate independently from hospital safety dashboards. They run excellent educational programs, but those programs may not be connected to the metrics that hospital leaders track most closely.
When simulation programs align with patient safety indicators, several important things happen. First, simulation becomes easier to justify strategically.
Instead of saying, simulation is valuable for training, simulation leaders can say, our simulation program is directly targeting the safety metrics our hospital is trying to improve. Second, simulation becomes easier to fund. Quality improvement initiatives often have dedicated funding streams. When simulation is embedded in those initiatives, it becomes part of the operational safety strategy. And third, simulation becomes more integrated into organizational learning. Instead of being seen as an educational department that occasionally runs scenarios, simulation programs become partners in system design, testing, and improvement. That shift, from education support to safety infrastructure, is where simulation programs can have their greatest impact. With that context in mind, let's look at 10 patient safety indicators that simulation programs are uniquely positioned to influence. Failure to rescue refers to the inability to recognize and respond to patient deterioration. In simple terms, it measures how effectively hospitals identify complications and intervene before the situation becomes life-threatening. Patients in hospitals often develop complications such as infections, bleeding, respiratory distress, or cardiac instability. What separates high-performing hospitals from lower-performing ones is often how quickly teams recognize the problem and escalate care. Simulation is particularly powerful in addressing failure-to-rescue scenarios because these events require coordinated team responses. Example simulation scenarios include sepsis recognition scenario. A patient develops subtle early signs of sepsis. Nurses must identify abnormal vital signs, recognize deterioration, and escalate care quickly. Postoperative bleeding scenario. A patient who has recently returned from surgery begins showing signs of internal bleeding. Teams must recognize early warning signs, initiate resuscitation, and activate surgical consultation. Postoperative sepsis is a serious complication that can occur after surgery when infection progresses into a systemic inflammatory response. The patient safety indicator measures cases where patients develop sepsis following surgical procedures. Sepsis is particularly dangerous because it can progress rapidly if not recognized early. Simulation can support improvement efforts by targeting surgical units, post-anesthesia care units, emergency response teams, inpatient ward teams. Example simulations include early sepsis identification. A postoperative patient develops fever, tachycardia, and hypotension. The scenario tests whether clinicians recognize sepsis early and activate the hospital's sepsis protocol. Sepsis bundle implementation. Teams practice initiating evidence-based sepsis bundles, including fluid resuscitation, antibiotics, and lab monitoring within the appropriate time windows. These simulations help clinicians recognize subtle signs of infection and initiate treatment rapidly. Postoperative respiratory failure occurs when patients experience significant breathing complications following surgery. This may require mechanical ventilation, ICU admission, or emergency airway intervention. Simulation environments that can address respiratory failure include operating rooms, post-anesthesia care units, surgical wards, and rapid response systems. Example simulations include an airway deterioration scenario where a recovering patient develops progressive respiratory distress. Teams must recognize hypoxia, start oxygen therapy, and escalate care, and a difficult airway emergency requiring rapid coordination between anesthesia, respiratory therapy, and nursing. Pressure injuries, sometimes called pressure ulcers, occur when prolonged pressure reduces blood flow to tissue. Although often associated with nursing care, pressure injury prevention is actually a system-wide responsibility involving nursing, physicians, and rehabilitation teams. Simulation opportunities include nursing unit training, interdisciplinary rounds, patient mobility teams. Example scenarios include patient repositioning workflow simulation. Teams practice safe repositioning strategies while coordinating among nursing staff and mobility teams. Risk assessment communication scenarios let clinicians conduct multidisciplinary rounds and communicate prevention strategies clearly. Patient falls remain one of the most common safety events in hospitals. This PSI specifically focuses on falls that result in patient injury. Simulation environments for fall prevention include inpatient rooms, rehabilitation units, geriatric care units. Example simulations include high fall risk patient transfer. Staff practice transferring a mobility-impaired patient safely from bed to chair. Fall response scenario. A patient falls in a hospital room and staff must respond appropriately, assess injuries, and escalate care. Simulation can also be used to test room layout and equipment placement that may contribute to fall risk. Central line-associated bloodstream infections, often called CLABSIs, are among the most closely monitored hospital-acquired infections. These infections occur when bacteria enter the bloodstream through central venous catheters. Simulation environments include ICU procedure training, central line insertion training, infection prevention programs. Example simulations include sterile insertion training. Clinicians practice central line insertion using strict sterile technique and checklist protocols. Maintenance protocol simulation. Teams practice line maintenance procedures and identify contamination risks. Simulation reinforces adherence to infection prevention bundles. Retained surgical items occur when instruments or materials are unintentionally left inside a patient during surgery. Although rare, these events are considered never events due to their severity. Simulation can be conducted in operating rooms, surgical team training programs, perioperative team simulations. Example scenarios include incorrect count scenario. A surgical count discrepancy occurs, and the team must follow escalation protocols before closing the patient. Communication breakdown scenario. The simulation tests whether team members feel empowered to speak up when safety concerns arise. Communication failures are one of the most common contributors to adverse events. Many patient safety indicators are influenced by poor handoffs, incomplete information transfer, or hierarchical barriers to speaking up. Simulation environments include shift change handoffs, operating rooms, emergency departments. Example simulations include shift handoff scenarios and speaking up scenarios. These simulations draw heavily on team communication models developed in high-risk industries such as aviation and NASA. Rapid response systems are designed to intervene early when patients begin to deteriorate. However, many hospitals struggle with delays in activating rapid response teams. Simulation environments include inpatient units, rapid response teams, and hospital-wide emergency drills. Example scenarios include a delayed escalation, where a patient's condition deteriorates gradually, and staff must recognize when to activate the rapid response system, and team leadership simulations where rapid response teams practice leadership roles and task coordination during emergencies. Section 11, Metric 10, Latent Safety Threats. Latent safety threats are hidden problems in healthcare systems that may not become visible until a crisis occurs. These can include missing equipment, poorly designed workflows, unclear emergency procedures, communication breakdowns. Simulation is particularly powerful for identifying these threats. In situ simulations conducted in real clinical environments allow teams to discover problems before patients are harmed. Example scenarios include new unit opening simulation. Teams test emergency response workflows in a newly opened unit. Code response simulation. A hospital runs an unannounced code scenario and discovers delays in equipment availability. These discoveries allow organizations to correct system weaknesses proactively. When simulation programs align their work with patient safety metrics, something important happens. Simulation becomes integrated with the core operational systems that hospitals use to protect patients and improve outcomes. Instead of functioning primarily as an educational service, simulation becomes part of the organization's safety infrastructure. That integration typically occurs across three major domains: quality improvement patient safety programs, organizational strategy. Let's talk about what that actually looks like in practice. Simulation and quality improvement. Most hospitals operate a formal quality improvement structure that continuously monitors performance metrics. These teams analyze trends in complications, adverse events, and operational failures. They identify where processes are breaking down and design interventions intended to improve outcomes. But many quality improvement initiatives face a familiar challenge. Policies can be written, protocols can be designed, checklists can be distributed, yet implementation often depends on how people behave in complex, real-world situations. That's where simulation becomes incredibly powerful. Simulation allows teams to test new processes before they affect real patients. If a hospital introduces a new rapid response protocol, simulation can be used to rehearse that workflow across multiple units. Teams can practice escalation, clarify responsibilities, and identify confusion before the protocol is rolled out system-wide. If a hospital is trying to reduce post-operative sepsis, simulation can be used to train clinicians to recognize early warning signs and activate sepsis bundles quickly. In this way, simulation acts as a bridge between policy and practice. Quality improvement initiatives often identify the problem. Simulation helps organizations rehearse the solution. Following a serious safety event, organizations can recreate aspects of the clinical situation in simulation to better understand what happened. Teams can walk through the workflow. They can identify where communication broke down. They can test alternative responses and redesign processes. Many hospitals now use simulation in partnership with patient safety offices to conduct event-based simulations, where lessons learned from real incidents are translated into training scenarios and system redesign efforts. Simulation also allows organizations to identify latent safety threats, problems that exist within the system but may not be obvious until a crisis occurs. For example, during an in-situ code simulation, a team might discover that critical equipment is stored in different locations across units, slowing response times. That issue can be corrected long before a real emergency occurs. Simulation and organizational strategy. Perhaps the most important shift occurs when simulation becomes connected to organizational strategy. Hospital leaders constantly balance competing priorities: patient safety, financial performance, staff training, regulatory compliance, reputation, and public trust. Patient safety indicators often sit at the intersection of these priorities. When complication rates increase, the consequences extend far beyond the clinical unit. There may be financial penalties from the Centers for Medicare and Medicaid Services. There may be scrutiny during accreditation reviews by organizations such as the Joint Commission. There may also be reputational consequences if safety performance becomes publicly visible. Simulation programs that align with these priorities become strategic assets. Instead of being viewed primarily as an educational resource, they become part of the organization's risk management strategy. For example, a hospital preparing to open a new surgical unit might run extensive simulation exercises to test workflows before the first patient arrives. A hospital implementing a new rapid response model might conduct hospital-wide simulations to ensure every team understands how to activate the system. A hospital struggling with communication failures during handoffs might implement simulation-based team training across multiple departments. In each case, simulation is not simply training individuals, it is strengthening the organizational system. A different question for simulation leaders. When simulation programs operate primarily as educational services, the conversations they have with clinical departments tend to sound like this. Would your team like a simulation session? Is there a training topic you'd like us to cover? Those conversations are useful, but they often position simulation as an optional activity rather than an operational necessity. When simulation aligns with patient safety indicators, the conversation changes. Simulation leaders can begin asking a different set of questions. What safety risks are most concerning to the organization right now? Where are we seeing increases in complications? What clinical situations generate the most serious incident reports? Where do teams struggle during real emergencies? These questions shift the role of simulation from training provider to organizational partner. Instead of waiting for requests, simulation leaders can collaborate directly with quality improvement teams, patient safety offices, clinical department leaders, risk management professionals. Together, they can design simulations that target the most important safety challenges facing the institution. In other high-risk industries, simulation has long been embedded in operational safety systems. Aviation organizations routinely rehearse emergency scenarios. Spaceflight programs conduct extensive mission simulations. These industries recognize that complex systems require continuous rehearsal and testing. Healthcare is increasingly moving in the same direction. Simulation programs that understand and engage with patient safety metrics will play a critical role in that transition. The strategic opportunity for simulation leaders, this alignment represents a major strategic opportunity. Healthcare organizations are under enormous pressure to reduce preventable harm while maintaining operational efficiency. At the same time, they are searching for practical tools that help teams prepare for complex clinical situations. Simulation provides exactly that capability, but its strategic value becomes most visible when it is tied directly to the outcomes hospitals are trying to improve. When simulation programs focus on patient safety indicators, their work becomes easier to justify, easier to fund, and easier to integrate into the broader mission of the organization. And ultimately, that alignment serves the goal that matters most: protecting patients from preventable harm. If you're leading or working in a simulation program, I encourage you to take a look at the patient safety indicators tracked by your own organization. Ask your quality and safety leaders, what safety risks are most concerning right now? Those risks may represent the most important simulation scenarios you can run. Simulation isn't just about practice, it's about protecting patients. If this topic is useful, let me know in the comments.